I have two abstracts with me. Both of them are phase 3 randomized trials. The first trial I chose to discuss it before the Astro trial because it talks about the relevance of pelvic radiotherapy. So this phase 3 randomized trial, which was from China, it compared patients who have intermediate risk following surgery, whether addition of chemotherapy over and above radiation, it adds to the outcomes. So if you look into the background and why the study was conceptualized, if you look that postoperative pelvic radiotherapy became standard of care after GOG in 92 and long-term follow-up study, which was published in 2006, which clearly demonstrated that if you add adjuvant radiotherapy to surgery in intermediate risk patients, there is at least a 7% improvement in progression-free survival. There was no difference in overall survival, but one needs to weigh, keeping into the allocation that happened into the radiation arm, that there were at least 7 to 8% higher number of adeno-CAs in RT arm, and there were higher number of larger tumors in radiotherapy arm. So the overall survival was bordering to significance, but not significant. If you look into the patterns of relapse that happened in the observation, If you look into the patterns of relapse that happened in observation as well as radiation arm, you can clearly see that the addition of radiation reduced mostly the local recurrence pattern. And if you see the differences in vaginal recurrences versus pelvic recurrences, there was a greater reduction in overall pelvic recurrence than vaginal alone. And there was also a reduction in distant metastasis with improved local control. So why was chemotherapy thought? So one would presume that early cervical cancer anyway does well. You add adjuvant radiotherapy, it's already doing well. What is the need of this kind of trial? But if you look into the overall relapse rate, despite adjuvant RT, at least 17% of the patients would still relapse either in pelvis or distant. And if you look into the results of Peter's trial, which used adjuvant CT-RT only in high-risk population, you can clearly see in the right-hand side graph that when chemotherapy was added, the maximum benefit was not distant, but it was local pelvic. And if you see the proportion of patients who failed locally in RT arm were 20 and in CT-RT arm was 7. That means that there is an additional benefit of addition of concurrent chemo, more local and less distant. And it was also seen in this study that patients who received less cycles of systemic chemotherapy, which is less than 2, the progression-free survival was very different when patients had also adjuvant chemotherapy. However, this is the high-risk population that we are talking about, but lessons that this high-risk trial gave us that probably intensification with further chemotherapy may improve with pelvic control. So there is this Chinese trial which randomized 165 patients, and it is not clear, but in the abstract it's written that few patients with 2B were also included, but with negative lymph nodes. 80 patients in CRT arm and 85 in CRT arm, which received 2 cycles, 3 weekly of paclitaxel and cisplatin. However, there was absolutely no difference in DFS and OS. Surprisingly, authors conclude that there is a benefit in overall survival. There was a trend in tumor more than 3 centimeters with addition of chemotherapy. However, if you just look into the conclusions, addition of chemotherapy in this particular trial did not benefit intermediate risk population. However, in my opinion, this is not the best design trial as there is lack of clarity about sample size and primary endpoint and what effect size was being expected. And we know from our lessons in at least the high-risk group that there is a clear reduction in pelvic failure with addition of concurrent and adjuvant chemotherapy. And we also know that dose intensity of chemotherapy is important. So I think before a final conclusion can be drawn about the intermediate risk treatment intensification with adjuvant chemotherapy, we'll have to wait for results of 2 more randomized trials, which is GOG 263, where there is intensification of concurrent chemotherapy, and RTOG 0724, where there is addition of adjuvant chemotherapy. And I think in next 4 years we'll have these answers. Talking about the second trial, which is a phase 3 randomized trial of standard versus IMRT for pelvic radiation for post-operative treatment of cervical cancer. The reason this trial is important is because post-operative radiotherapy does lead to a substantial proportion of patients coming up with bowel toxicity, few with obstructions. So before this trial, there was no level 1 evidence for superiority or lack of it of postoperative IMRT, either in terms of physician or patient reported outcomes. At present, internationally, there are only 2 randomized trials which are looking into postoperative IMRT. The first trial is from our hospital, which is randomizing around 300 patients. It has accrued 211 patients. The interim analysis was presented as plenary in Astro last year, and there was no difference between standard radiation and IMRT. The second trial, which is what I'm presenting, it's Time C trial. It has completed accrual, and the primary endpoint is during treatment toxicity. And if you look, the results from our study, which were available prior to results of this study, which became available, there was no difference in acute gastrointestinal toxicity with the use of IMRT. However, our study had more concurrent chemotherapy. If you look into the primary endpoint of the Time C study, which I'm presenting, the primary endpoint was acute gastrointestinal toxicity at week 5 from start of pelvic radiotherapy, not as measured by the physician, but as far as patient-reported outcomes are concerned. The study planned to randomize around 289 patients into standard RT and IMRT. 278 patients were required for primary analysis, but 225 were evaluable at the time of presentation at Astro. Patients were stratified into external radiotherapy dose, concurrent chemo yes or no, and disease site endometrium versus cervix. And because there was lack of baseline data about patient-reported outcomes, the study assumed an effect size difference between the standard and the test arm, and the study assumed that if there will be a moderate difference that will be detectable at week 5. So if you look into the patient characteristics, they were fairly equally balanced as far as strata is concerned, as far as radiotherapy dose, choice of chemotherapy or not, and primary site. However, if you look into the primary endpoint of the study, though authors report that there was a clear difference between IMRT and 3D CRT, you can see in the numbers above, they are quite less than 278 which were required for the primary analysis, and few patients have been omitted. And even though there is a difference between the IMRT and 3D CRT arm, the standard deviations are as much as the mean. And if you look into how the toxicity evolves, the primary endpoint is assessed at week 5, which is the first red circle that you see. At week 5, the difference between the 2 lines, but as patients progress with follow-up, all the difference that you're seeing at week 5 disappears. And if you concentrate on the third circle, which is below, you can see that there is difference of at least 20 patients for analysis of primary endpoint, and there's no explanation provided for the lack of this imbalance. The study concluded that pelvic IMRT reduces acute patient-reported toxicity compared to standard pelvic radiotherapy. However, there's a clear difference between what the study presumed and what was seen. It presumed an effect size of 0.40 and observed effect size was 0.27, leading to lower power. The presumed power of the study was 0.85 and the reported power is 0.53. And to come to this kind of conclusion, at least 500 patients would be required, and study randomized around 289 patients. So the question is that can adjuvant IMRT be recommended standard of care on the basis of results of these studies? So the first observation is that it's an underpowered study. Most of the symptoms with which they report benefit were not the primary endpoint. The difference that was seen at week 5 disappeared 6 weeks after completing treatment. 75% of the patients in this study received radiotherapy alone, and when patients receive concurrent cisplatin, it's the chemotherapy rather than the radiotherapy technique which may drive toxicity. And hence the impact of IMRT in the setting of concurrent chemoradiotherapy is still not known. And secondary analysis from our study at Tata Memorial Center had reported no difference. So thank you very much.